Thanks for joining us. I'm Manesh Patel from Duke University, and this is the Heart.org booth at the American Heart Association's 2011 meetings. And I'm here with Dr. Choudry from the Harvard Medical School, who's just presented a great late-breaking clinical trial. Thanks for joining us.
It's a pleasure to be here.
Can you tell us about the MI FREEE study?
Yeah, so we were interested in figuring out the contribution of cost to the problem of non-adherence. So we knew that non-adherence to essential medications like those prescribed after myocardial infarction, rates are extremely high. About half of patients adhere to their medications over a year or two period after starting them. And there are many reasons why patients don't adhere, but it appears that costs are a central reason. And so we wanted to figure out what would happen if costs were eliminated. And this is part of a larger movement in health policy called value-based insurance design, and what would happen to clinical outcomes and to spending, and that was really the motivation for the study.
So tell us a little bit how the study was designed and what you guys found.
So this was a cluster randomized study in which we randomized plan sponsors. So we randomized individuals within plans. Plan sponsors are employers or other entities that are responsible for delivering a patient's insurance coverage. And so we identified patients who'd been discharged from hospital after an MI. These were all Aetna beneficiaries, so we did this in partnership with a large insurance company, using health services claims to identify them, and then randomize them, and patients either received full coverage or their usual levels of coverage for 3 classes of drugs: statins, ACEs or ARBs, as well as beta blockers. And what full coverage in this case meant was no copays, no coinsurance, no contribution to deductibles for any drug, branded or generic. So patients were contacted in both groups and told them that taking their medications is very important. It was a very brief interaction, and people in the intervention group were also told of the benefit change, but there was no other intervention, and all prescribing decisions were left to patients and their doctors.
Wow, so patients in the randomized arm got free medications for those 3 meds.
Absolutely. So they paid no cost sharing, no copays, no deductible contribution either.
Wonderful. So tell us what happened to adherence and what happened to outcomes.
Right. So the primary outcomes of the study were clinical. We wanted to answer the so what question up front. So what we found is that adherence increased for each of the classes that we studied by about 4 to 6 percentage points in absolute terms, or 30 to 40% in relative terms. So our primary outcome was a composite outcome of first major vascular event, which is fatal or non-fatal MI, unstable angina, heart failure, stroke, or revascularization, which of course is bypass, angioplasty, stent. And that outcome was reduced by the intervention, but not significantly. We had a couple of pre-specified secondary outcomes. So one of them was the primary outcome, in which we eliminated revascularization. We thought that revascularization is a bit of a discretionary procedure in some hands, and as a consequence, if we take that out in a pre-specified way, we'd see what happened. And lo and behold, that was reduced by 14%. So rates of events that led to hospitalization that we consider to be non-discretionary were reduced. Similarly, when we looked at total events, so most trials look at time to first event, but it's important sometimes to know whether a patient has an MI and a stroke, not just another MI. And so we looked at total events, and that was also significantly reduced by 11%. The last major set of outcomes that we looked at was cost. And there are really 2 cost things to consider. So one from the patient's perspective, and then overall, or from the insurer's perspective. And from the patient's perspective, of course, drug costs went down. This was by design. But medical costs also went down, the amount that patients had to pay to see their doctors or be admitted to the hospital. And combined, that was about $500 a person that costs were reduced, and that was highly significant. Overall spending was a little lower in the intervention group too. It was about $6,000 lower in the intervention group, but that was not statistically significant. So our interpretation is that as a whole, costs did not increase. So this is a quality improving intervention where costs did not increase. Patient spending went down. Health outcomes seem to have been improved, and adherence went up.
Dramatic findings. So where do we go next? What does this mean for the country?
So I think it's important to acknowledge what kind of study this was. This was an implementation study about designing a way to get patients to do what we already hope that they will be doing, using highly recommended therapies for post-MI patients. And so I think this is an economically dominant study. It improved quality and it reduced costs, and there should be really little obstacle to now scaling this up. We designed the study in a way that made it readily scalable. We could do this tomorrow. We used health services claims to identify patients. We contacted them by phone and by mail. It was a very low intensity intervention, And so I hope that insurers will adopt this. As it turns out, Aetna, who was the sponsor of the study, has said that as of January 2013, they will be implementing this plan for their post-MI patients. That their patients were covered by their given plan sponsors will face no copayments for generic medications and a much reduced copayment for branded medications. And so hopefully other insurers will follow suit.
Well, thanks for providing an important study, and thanks for joining us here today at
Great.
heart.org.
Pleasure.